All right. Hello, everybody. Thank you for joining this morning on this webinar around providing effective clinical supervision and in early psychosis programs. Before we get started, I want to make a couple of announcements. One, the technical assistance team will be conducting a survey on kind of the technology and how well these webinars work and the usability of these webinars, and that survey will be available to you at the end of this webinar series. Then we also want to make note that this webinar is part of a larger webinar series around early psychosis work, with our next one being February 22nd on integrating early psychosis into larger systems of care. Those are my announcements. I guess my other announcement / disclosure is I'm a bit under the weather today. Having small children, it just does not seem that I can shake these colds very well. So if you have difficulty hearing me, or if I fall into a major coughing fit or something, I will do my best to reorientate myself and get back to you. I want to acknowledge that this webinar is hosted by us. I'm again with the ESA Center for Excellence, and we're partnering with the National Technical Assistance Network for Children's Behavioral Health, operated by and coordinated through the University of Maryland. So thank you for them, and I'm very happy with this partnership, and enjoy that we're able to put these webinars on for you all. All right, I think it's important, I guess, to introduce myself. Since I don't get to see you all, and we're not doing this in person, I did put a picture of myself up on the screen. I am the one on the left, if you were wondering. This is a picture of myself and my child when she was 1 year old. At 1 year old, I felt this is an appropriate picture because this is my attempt to supervise her in eating spaghetti. Did not go as well as planned, which I think kind of parallels the process of supervision in early psychosis programs. We sometimes enter a supervision practice with good intentions, but the outcome doesn't always go in the favor in the way that we would like. Also, sorry, so that's me. I'm also the director of the ESA ESA Center for Excellence, and my role is to provide clinical supervision, clinical consultation. We'll make that distinction later in the webinar, to all of the early psychosis programs across Oregon. So that's the role that I'm playing right now. We jumped ahead a little bit. That was my fault. I'm quick to the trigger, but I do want to take a poll on who is on the line, so I get a sense of who I'm speaking with, and I can make some modifications to my talk based on my audience. So if you spend a second or two and complete this poll. Okay, looks like the poll is now closed. Hopefully everybody had the opportunity to vote. Can we get a shot of the results? Oh, here they are, I hope. I'm hoping everybody can see the results. It looks like the majority of those on the call are a mixture of administrative supervisors and clinical supervisors, with some others and some clinical staff on the line. That's a nice audience to have, since we'll be talking a lot about kind of the role of clinical supervisors and some of the differences between clinical supervision and administrative supervision, recognizing that some of you may play both of those roles and how to manage that. Okay. So what I'm going to be doing, or to attempt to be doing today in this webinar, is discussing what clinical supervision is in a broad sense, then discussing some theories around clinical supervision, and then trying to tie that into clinical supervision in first episode psychosis programs or early psychosis programs. That'll be kind of our agenda for the day. And we do have a chat box. I forgot to mention that you can enter questions on the chat. I do have my colleague Tamara Sale on the line, who's the director for the ESA Center for Clinical Excellence, who can also respond to questions if I'm unable to while I'm speaking. So please feel free to ask questions, provide comments in the public chat box as we go along. All right, so first and foremost, let's talk about what clinical supervision is and what are some effective clinical supervision's approach. So the clinical supervision, the role of clinical supervision is you play multiple roles as a clinical supervisor. You certainly can act as a teacher. That might look like teaching your staff early psychosis models and teaching them how to implement them. You may be acting as a trainer and getting more specific into the specific components of early psychosis models. You can act as a mentor. A mentor might be to support your supervisees in kind of not only learning the models, but also kind of developing professionally. You also have that role as the evaluator and monitor. You are, in some ways, a gatekeeper. You kind of evaluate their progress as well as, maybe potentially engage in discipline if you play that role should something go awry. In clinical mental health, we have two primary roles in clinical supervision: those who play the role of clinical supervisor and those who play the role of administrative supervisors. Those are very distinct roles, although I fully acknowledge, and sometimes in rural areas and smaller areas, a staff may play both of those roles or wear both of those hats. But the role of the clinical supervisor is really just that, to provide clinical support to the supervisee. And their primary goal is to support the supervisee. So that's the person that they're primarily working with. Whereas the administrative supervisor's role is to support the agency. The administrative supervisor may be much more interested in productivity, billing, hours, vacation time, those type of roles. I think it is important, if possible, to keep those roles separate. That they actually play very different components, whereas, again, the clinical supervisor is supporting the individual, whereas the administrative supervisor is supporting the agency. And if you are in both roles, you're inherently kind of creating an environment where in your clinical role, your clinical supervisee may not feel as safe in kind of disclosing or in engaging in some forms of clinical practice. And on the other hand, you as the administrative supervisor may be overly focused on, well, shoot, we have to make sure you get all these hours in and make sure that your timesheet is filled out correctly, and then you don't give adequate time to the professional growth of your supervisee. That being said, again, I do recognize, and we have this in Oregon as well, where some staff play both of those roles. If you do play both of those roles as a supervisor, I think it is important in your supervisory meetings that you distinguish what role you are playing at the time during the meeting. That might look like a very clear agenda. It starts off with administrative role. We're going to cover some administrative roles as quickly as possible, and then we're going to move into the clinical supervision portion of the meeting. Again, I do think it's important to call these out as different roles, particularly if you're playing both of them. It's also important to distinguish between the role of supervision and consultation. A supervisor certainly has evaluative ability over the supervisee, whether that's giving them direct feedback on how they are doing in their practice. In some cases, it might be reporting to a licensing board. And if that supervisor does have an administrative role, it might be involved in the hiring and firing of that supervisor. The supervisee, sorry. The supervision, the supervisor also may be held accountable in some ways for the supervisee's actions, should one of those actions go awry. Versus consultation is more of a role that I play with the Center for Excellence, where I can go into sites around Oregon, other early psychosis sites, and then provide them with feedback around differential diagnosis, how they're implementing the model, how that's working. Again, provide some clinical consultation on what to do with a client if they're feeling stuck. I can play that role, yet I don't have the evaluator power that the direct supervisor has, nor am I necessarily held accountable if something goes poorly with my recommendation. Hopefully that didn't happen. There are definitely some differences in the consultation role versus the supervisor role, and obviously the consultant, such as me, is not necessarily employed by the agency. Also, as a consultant, whoever I consult with is under really no obligation to follow through with my recommendations. Again, I'm just there providing the support, whereas in a direct supervisor role, the supervisor would be, needing to kind of follow direction there. So, for the purposes of this talk, we are going to be focusing on clinical supervision in the kind of the clinical supervision role. That'll be the majority of what I'm referring to when I'm referring to supervision throughout the course of this particular talk. I think it's important to kind of talk about what are effective supervisor behaviors. I mean, what makes a good supervisor? If we look at Campbell's research on what supervisees kind of report as good supervisors clarify expectations and roles, similar to what I was talking about already, that if you do play an administrative role in your agency, that you clarify that you're in both roles, a clinical role, a clinical supervision role, and an administrative role. They're accessible and available. They're not the unavailable supervisor. They take the role of supervision very seriously. And what does that look like behaviorally? It looks like the supervisor schedules frequent supervision, whether that's weekly or every other week, at a consistent time with very few cancellations. The supervision is held sacred in the same way that a therapy session would be held sacred. You don't miss supervision. The supervisor creates a safe environment where the supervisee does feel safe to report challenges, whether those are clinical skill deficits or personal challenges. Maybe a bias is coming up. Maybe some countertransference is activated. A good, safe supervisory relationship allows for that supervisee to talk about that, to be open to bringing that up without fear of some type of punitive nature, which, again, why it's so important to distinguish between administrative and clinical supervision roles. A good supervisor is open to ideas and has a primary goal of moving the supervisee kind of through to their own personal goals. So much like we create treatment plans for clients, a effective supervisory technique is they'll create a supervision plan for the supervisee. And that plan has measurable objectives and specific interventions that the supervisor is applying in the supervision session with the goal to complete goals and to help them move through the process and develop as professionals. in some ways, a good, effective clinical supervisor is to help train a supervisee to the point where they can take their job. That a student walked in, I was talking to a student the other day, and she told me, you know, I'm really thinking about applying for my doctorate degree. And I said, that sounds like a wonderful idea for you to try. And she looked at me and she said, well, that would mean that maybe you and I would compete for jobs someday. And I would say that would be my primary goal. That's kind of one effective of supervisor behavior. Help your supervisee move through their professional goals and their process. Some less desirable supervisor behaviors, things that the Campbell's research shows are not helpful, are the supervisees that are inconsistent, meaning that, the supervisors that are inconsistent, meaning that they schedule supervision sessions but cancel frequently because something comes up with the agency. And that we certainly are aware that we do come up and we do need to cancel from time to time, but the supervisor that consistently cancels because of an administrative meeting or because of a crisis or because of something else that's happening in the agency sends the message to the supervisee that this really isn't that important. So that inconsistent nature. Those who are that are overly directive, so supervisors that their role is just, if they feel their role is just to tell the supervisee what to do. So this is the supervisor that has a checklist at a supervisory meeting and says, okay, you're going to do this, 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 and this. I've just supervised you. So it becomes all about direction and not about growth. It's another less desirable supervisor behavior, which in some ways sounds good, is the supervisor that says, you know what, my door is always open. Now, although it's great to be flexible as a supervisor and be available for your supervisees, not having a consistent time that honors the supervisory practice, again, sends the message that supervision isn't that important. Just kind of reach out to me when you need me. It doesn't really honor a supervision process. Again, other behaviors we want to watch for is not following the supervision plan. The supervisor who doesn't follow through with requests of the clinical supervisee around helping them move forward in their career. And then supervisors who essentially may have some poor boundaries and don't understand that the supervisor role is a role of power. When you're in a supervisor role, you have both power and knowledge. When you have power and knowledge, that equals responsibility. And you need to hold that responsibility sacred. So that might mean setting some poor or less desirable supervisor behaviors, maybe not setting good boundaries, maybe having too close of relationships with your supervisees, friendships outside of work, overly active on Facebook or something like that. I do think it's important to set a role that you still are in a position of power. And that certainly can create challenges when you have multiple supervisees and you as a supervisor are friends with some but not friends with others, and send some certain mixed messages about the supervision role. So that's just a general summary of the role of clinical supervision, or what is clinical supervision, with some desirable and less desirable behaviors. All right, we're going to talk about now some supervision models. Now, when it comes to models, there's good and bad processes with models. Probably some positive aspects of models, whether they're supervision models or treatment models, is that they do provide us with some type of framework and representation in which to work. So in a lot of ways, they help us think outside the box. They give us some direction on how to work with the supervisees. They also can help us conceptualize and understand complex phenomena. And they can also provide a framework for experimentation or things to do with your supervisees. That being said, some models appear to be overly generalized. They're kind of limited in scope, and they lack explanatory precision. Or they may not just fit with the supervisee sitting across from you. And again, I think that's true also for clinical models, which kind of provide us with a nice base from which to work, but may not exactly work with the person that's sitting in our office at that particular moment. So with any model, supervision models included, I do encourage you to take some liberties with them, use them to think outside the box in your supervision practice, but at the same time be flexible. And make them work for your supervisee in the same way that we try to make our clinical models work for the clients that we serve. Let's talk about the first model that I want to bring up, and then I will attempt to move these models into specific first episode psychosis practice. The first model is Janine Bernard's discrimination model. I think this has a ton of relevance in the work in first episode practice. Bernard's model, discrimination model, asks us to consider ourselves to play one of three roles as we're working with our supervisees. We don't need to stay in these roles all the time. We don't need to even stay in these roles throughout a single session. You can switch from a teacher role to a counselor role to a consultant role, all within the same session. The key is to be clear on which role that you're in when working with your supervisee. So you have one of three roles. So the teacher role is just that. The teacher role, is a role that includes kind of how to learn new skills, how to be aware of your professional behavior, how to learn a very specific intervention. So again, it's very much teaching the aspects of the work that you do. And in the case of a first episode psychosis program, it might be teaching a very specific model. It might be teaching how to do CBTP, cognitive behavioral therapy with psychosis, as part of your supervision. She also, in this model, encourages going in roles beyond that. I think a lot of supervisors feel very comfortable in the teaching role, but I would also want us to consider expanding that role as clinical supervisors. So the other role is the counselor role, and that doesn't mean that you're taking on a role as a professional counselor and you're bending boundaries in that way. What it means is that you're attending to your supervisee's potential interpersonal issues that may interfere with their clinical work. It means paying attention to countertransference and biases that may be present in your supervisees when they work with specific clients, what reactivity they have. If they're frustrated with a client, exploring that frustration without judging that frustration, saying where that frustration may come from. And then finally, the consultant role. And in the consultant role, if you can find yourself being comfortable in this role, Bernard in her work says you're moving through the supervision process. You're becoming an effective supervisor. Because in this consultant role, you're aiming to work with a supervisee where the supervisee is taking the lead in the majority of your supervision sessions, where they're sharing their ideas and you're asking questions of how they came to those ideas and what they think may or may not work versus telling them what will work or what not work. And then also feeling comfortable with the supervisee in a lot of ways, kind of flying on their own and taking some risks and then giving you feedback on how that works. She said, within each of these roles, you'll be focusing on three potential skills: intervention skills, conceptualization skills, and personalization skills. Intervention skills involve focusing on what the actual implementation of a specific technique or strategy may be. So again, that is very much, oftentimes when you're in a teacher role, you're focusing a lot on intervention skills. You're teaching somebody how to engage in a very specific intervention. You're teaching them how to engage in CBTP. Although you certainly can be a counselor with intervention skills and a consultant with intervention skills. And we'll talk more about how that ultimately works also. The next focus would be around conceptualization skills. And this one is more of a cognitive skill that reflects deliberate thinking and case analysis on the part of the supervisee. So this may look like asking how they came to a very specific diagnosis. If the supervisee has diagnosed somebody with schizophreniform disorder, discussing how they came to that very, very, very specific diagnosis, or potentially working with them to conceptualize how a cognitive behavioral therapy approach may work for one particular client, or how a solution-focused approach may work with a particular client. And then the final focus is personalization skills. In this particular one, you're focusing on, again, potential reactivity, potential how the supervisee kind of feels about working with a particular client, how their behaviors and attitudes are present, and where those may ultimately be coming from. When bringing up personalization skills, where you want to help supervisees get is where they're not feeling overly defensive. If you ask about, I noticed that you are feeling very frustrated about that particular client, or you just said, that client will probably never get better because they continue to smoke marijuana. Just paying attention to, where those kind of reactivity is coming from, and really focusing on those skills. So it gets drawn out in the form of a matrix. This is something that you as a supervisor can use yourself to conceptualize what specific role you're in and what specific intervention that you may be playing with your supervisee. So are you a teacher focusing on interventions? Are you a counselor focusing on conceptualization? Are you a consultant focusing on personalization? And this is kind of the crux of the discrimination model. What role are you playing and what skill are you focused on? Again, not perfect, but it kind of helps us think outside of the box and really formulate our thinking around supervision, as opposed to the supervisor who just says, hey, what do we need to be talking about today? Let me show you how it might look with a first episode psychosis program. It may look something like this. So if you're a teacher in the teacher role, and we're focusing on an intervention, you may model or teach how to explain a diagnosis to somebody who's been first diagnosed with a first episode psychosis, and how that might look different from somebody who's been diagnosed with an attenuated psychosis syndrome. So really teaching your supervisee how to explain a diagnosis. And again, these are just examples that could work in a first episode psychosis program, and there are tons of obviously interventions that you could be teaching in that role with that particular focus. How this works as a teacher with conceptualization might be how you discuss how to apply cognitive behavioral therapy, or that lens anyway, to a particular client. But again, in that role, you're teaching it. You're not necessarily in a consultant role where they're explaining it to you. And then in a teacher role with personalization, as a teacher, you might explain how working with first episode psychosis may impact the supervisee. What type of emotions tend to come up with supervisees that are working in this field, whether it's a sense of trying to be a savior or a sense of blame that may come up, but kind of teaching those natural responses to working with clients that are experiencing first episode psychosis. A counselor intervention, would be that if your supervisee comes in making statements about, I just don't feel I can help this client. They just will not take their medicines. They won't stop using marijuana. So I think in the counselor role, you're you're falling down on basic counseling skills, empathizing why the supervisee may feel that way, and kind of that seeking first to understand their process before you can be understood. Then you may switch over to a personalization skill around where their feelings may be coming from. So sometimes it's important to start with an intervention and then move to personalization, really when it comes to personalization, resisting feelings that come up within supervisees. In a conceptualization, you may discuss the impact of previous experience with cognitive behavioral therapy in that counselor role. It's not unusual that supervisees who enter in this first episode psychosis program who don't have a lot of experience with the intervention used may say, oh, you know what, I've tried CBT before, it didn't work. I did have lots of clients. It wasn't effective. So you may want to discuss that with them and with their previous experience, versus just trying to kind of teach how it does work and showing all the research on why it's effective. And then we've already talked about kind of the personalization counselor, or the personalization focus for the counselor role. When you're in the consultant role, one intervention, may be that, if you have a supervisee who's having some reactivity to a particular client or to a particular set of clients, you may support them in seeking their own therapy or their own counseling for these biases that may be coming up. And, of course, a non-shaming way and a non-detrimental way that personal growth is important to understand where our biases come from, because we all have them, and to ignore them is in and of themselves poor practice. But to recognize that we have them, and that sometimes we need to talk about them, and that may go beyond the scope of what happens in supervision if it's really impacting a supervisee, and making a decision for a supervisee to seek out their own counseling to work through biases is, in fact, a very healthy and shows a good sense of growth mindset, in the work that we do. In terms of conceptualization, in this case, it would be supporting the supervisor and support and understanding why the supervisee is choosing to use cognitive behavioral therapy. So in this case, it wasn't you instructing the supervisee to use cognitive behavioral therapy with psychosis for a particular client. It's when your supervisee comes to you and says, you know what, I'm thinking of using cognitive behavioral therapy with psychosis with a client, and you saying, tell me about that. Tell me what you're conceptualizing about this client where you feel that would be an effective approach in working with them. So in this case, you're much, in the consultant role, you're much more collaborative. Now, this may not be a role that you play early on in the supervision process. It may be something that you play a little bit later. But ultimately, it's where you want to be as a supervisor. You want to be spending more time in that consultation role where you feel like you're wearing that consultation hat. If you're as a supervisor, if you feel you're spending a lot of time in the teacher role, if you've been working with somebody and you've been in the teacher role the entire time, it's time to explore what you could be doing differently as a supervisor to move them into a consultation role, or potentially what's keeping the supervisee stuck in where they're constantly wanting to kind of learn a skill, but they're not implementing a skill and coming back and being able to tell you why they came to that decision to use that skill. And then finally, with personalization as a consultant, discussing, the supervisee's biases following their lead. So it wasn't you bringing up that there may be a bias present, but that they bring up that there is a bias present, that they know that they had a reactivity to a client, and they want to learn more about that, and they want to bring that to you for supervision. These are the supervisees that you really want, or you want to help them move towards when they recognize that something is coming up for them and they want your support, or at least they want to talk about it in supervision. If you have a supervisee that does that, you've done a very good job of creating a very safe place for your supervisee to talk about that, especially when they're taking the lead. You've done a good job developing that particular skill. So this is, and probably can hear me. I lost a little bit of connectivity in my, oh, there it is. Sorry about that. Hopefully I'll be back online here in a second. Have the slide move forward. Okay, perfect. Thank you very much. Okay, now I'm going to move on to developmental models. And there's a wide range of developmental models that exist within the supervision practice. Probably my favorite model is Sullenberg and McNeil's integration developmental model. And I'm going to pull from that model a little bit. And at the end, I have some resources and some names for you if you're interested in looking up these models yourself. But the developmental model is a model that conceives your supervisee as moving through developmental stages with your lead. And again, the goal of the supervisor in working within a developmental model is to assist the supervisee in moving through these stages. And then within each stage, there are specific skills that you as the supervisor want to be focused on. And this model actually works quite well in coordination with the discrimination model, in that, you know, somebody who's in the early, maybe working stage in a developmental model, or an early stage of their development, it's perfectly okay to spend a lot of time in the teacher role. But if they move through, you may want to spend more time in a consultant role as you're really moving them through the developmental process and moving them to the final stage, which in developmental models is referred to the integration stage. So let's kind of go through some of these stages that this model proposes that supervisees go through. Now, one thing about this isn't about necessarily experience in a mental health field. It could be about experience in a specific component of a mental health field. For example, you in a first episode psychosis program may hire somebody with years of experience in mental health. Maybe they've worked with a severe and persistent mentally ill population. Maybe they've worked at a state hospital. So they've got a ton of experience in working with individuals with psychotic disorders, but they have limited experience in working with individuals with first episode or maybe even attenuated psychosis. So for them, although in one phase of their career, working with an SPMI population, they might be at an integration stage, but now they've shifted over to you, it may be effective to conceptualize them in an early developmental stage and focus on those particular skills. So this isn't necessarily about experience in the field. It could be growth within a very specific skill set. All right, let's go through some of the stages. First stage is the orientation stage. In this particular stage, what you're trying to do as a supervisor is really set the stage for the importance of clinical supervision, that this will be held sacred in our work together. So you'll have an initial meeting, and in that initial meeting would be around what supervision looks like, really clarifying those roles, going back to those effective supervisor behaviors that we talked about early on in this webinar, and what supervision is, what role you're going to play, or, you know, defining what clinical supervision is versus administrative supervision. And if, again, you're one that plays both of those roles, being clear to delineate that and recognizing that there is an inherent kind of power differential and different roles with an administrative supervisor that a clinical supervisor may not have. So being clear on what role you're playing throughout the supervision process. One thing that I like to do with supervisees is actually have a supervision agreement, which is kind of much like an informed consent that we might give a client, which lays out, and I have examples of my own if people are interested in seeing that, and certainly can send it to you if that's something you want to see and you're interested in. But it lays out kind of the expectations of supervision. It lays out what model that you may be using in supervision. It lays out what's expected of supervision, what you want your supervisee to bring to the session, whether that's a case or case conceptualization, whether that's a video because you're looking at fidelity to a CBT model, or, you know, whether that's some cultural or biases that may be coming up that you may be covering in supervision. So really laying out what the expectation in a very clear way of what the supervision is, how often you're meeting, when you're going to be meeting, what to do in if a cancellation occurs, what to do if there's a conflict between the supervisor and the supervisee. How do you negotiate those conflicts? I think all that can be laid out in a kind of an agreement. I think one thing that we see in first episode psychosis programs is because we're following, oftentimes these programs are following the coordinated specialty care models, which involve a good number of different disciplines. You as a supervisor, maybe you're a psychologist, but you're supervising a nurse, kind of laying out those expectations in supervision on what you can and can't do in terms of their supervision, where you can engage them in recognizing biases, you can engage them in explaining and teaching the specific FEP model. What you can't do is how to help them measure metabolic syndrome. But what you might be doing is helping them find somebody who can be a mentor to them, but it's still not necessarily a supervisor. So yeah, really clarifying those expectations, and with this, really starting to develop that relationship and setting your roles, and then setting supervision goals. And again, I really feel that supervision in a lot of ways should parallel the treatment process with clients. So much like we set expectations with clients with informed consent on what we can do and what we can't do, when we're going to break confidentiality, when we can break confidentiality, when we can't, all that, we do that with our supervisees as well. And then we actually then start setting a plan. And so I do have a supervision plan that I use, which in some way parallels a treatment plan. And I do that very intentionally because part of the expectation in first episode programs and in community mental health in general is that you're going to write a treatment plan. And for somebody who's new to that field, it's nice to kind of parallel that. In some ways, you're kind of teaching how plans should work. Now, if you create a supervision plan and just file it away to be reviewed in a year, I've certainly experienced my share of work plans that got written and I was excited about it, and then they never got brought out again until a year later. That sends a message that the process isn't that important. So you really want to be setting goals that you're following, and then you revisit those goals kind of throughout supervision in the same way that we're supposed to be working with our clients, kind of following that step-by-step process. So I have copies of a supervision agreement, happy to send you those. I have a supervision plan, and I have even supervision notes, which, as you're probably going to guess, will parallel progress notes. So then we know when we write progress notes for our clients, those progress notes are supposed to be tied back to our treatment plan. Very similar with supervision, that our progress notes should be tied back to our supervision plan to show the supervisee that we're helping them develop along the way. And if the supervisee isn't meeting a goal, why not? Or what can we be doing differently? Yeah, I can email those that can be sent out to you all. All right, so it looks like I can send those to the Institute and they'll be sent out to everybody. I will do that at the end of this webinar. Okay, so once you've kind of met that orientation stage, it's really an introduction stage, we start to move into a working stage. And so in this particular stage, we're starting to look at where skill deficits may be present and where there may be some affective or bias issues that could be coming up. And again, this isn't to use some pejorative thinking about your supervisees. It's a natural process. When you enter a new field or a new set of work, like a first episode psychosis model, which is oftentimes very different. I've done this long enough where I've worked with supervisees who've had tons of experience in the field and then jumped into an FEP, coordinated specialty care model, and it's a big shift in thinking for them, and there's a lot of reactivity, and there's a lot of affective issues that come up, and there are some skill deficits. So really trying to understand what those are, maybe those get laid out in the supervision plan and working through them. Part of the working stage is to help translate those concepts learned in supervision. So if you're teaching the components of a coordinated specialty care model to your supervisee, you want to help that actually gets used in practice. One technique in doing that in the working stage is instead of asking your supervisee, hey, what approach did you use with that client that you said that you were feeling stuck with? And they said, oh, I used motivational interviewing. Instead of allowing that to end, say, all right, let's move to a role play. I'm your client. Show me how you used motivational interviewing with that particular client. So really helping them translate those concepts. This is where videos are incredibly effective. Still the best practice in supervision, where when we actually see supervision work, and what I mean by that is supervision actually impact outcomes. Unfortunately, there's very few studies that actually suggest that supervision can be helpful in impacting clinical outcomes. It's just an unfortunate finding in our field. But then the ones that we do see where supervision does impact clinical outcomes, meaning that supervision can be linked to outcomes of clients, is when we really are deliberate in our practice as supervisors around helping supervisees translate what we're talking about to actual skill sets. So role play, videos of the work are the best, still kind of best practices in supervision. So it is almost going back to our graduate school where we had to submit videos and the supervisor would review, our teacher or instructor would review videos. I would love to see that practice more in the field. And I think we are seeing it more so in first episode psychosis programs because we're integrating so many fidelity practices like CBTP and motivational interviewing where there do have to be video reviews. I do think that's a good practice. I also, again, not only would like to see it in fidelity reviews, but also within the supervision sessions themselves. Certainly assessing strengths that the supervisee has. You know, in our model at Oregon, we use strength assessments with our clients. I think a nice strength assessment for your supervisee is also helpful to just kind of help them move through their strengths. And then where there are some areas of growth, so they'd like to, the more polished supervisee will be able to tell you their areas of growth. But oftentimes in the working stage early on, you're going to be needing to pull out those areas of growth. And again, a good sign is if you get limited reactivity from the supervisee when you point out those areas of growth. And then using that discrimination matrix that I showed earlier to assist in what particular focus you're going to be using, whether it's intervention, contextualization, or personalization, and what role you're going to be playing. And when using this discrimination matrix in supervision, I think it's fair to be very transparent and say, you know what, I'm going to put on my counselor hat right now. I was in the teacher role, but I'm going to put on my counselor hat. I'm noticing that you're feeling quite reactive to this particular client. So just making that very transparent distinction in the supervision process. Next stage is that transition stage where you're trying to help move the development of self-awareness. So you're spending a lot less time in that teaching role and you're starting to see a little bit more consultation, or you're feeling that. And you should be moving that way too. We are also, not only do supervisees sometimes show signs of resistance, supervisors show signs of resistance where we want to stay in that teaching role because we feel very comfortable. We want to remember that our goal is to help our supervisees transition, help our supervisees kind of move through the process. So sometimes we need to challenge ourselves as supervisors to be in a consultant role and allow the supervisee to take more of the lead. So when the supervisees are in that transition stage, we certainly see much more self-awareness. So this is when the supervisee starts to bring up their own biases. This is when the supervisee is really asking for direct feedback, not only from you, or bringing feedback from clients into the session, asking what they could be doing differently, where they're recognizing that a certain practice may not be working well and they want to improve. Refer to that as a growth mindset versus a fixed mindset. The fixed mindset supervisee thinks that when they've done an intervention, and if that intervention didn't work, that's the client's fault. Where growth mindset supervisee is, I've done an intervention, I did CBTP and it didn't work. I'm wondering what I could be doing differently, and then them seeking that out, we refer to that as a growth mindset. We want to, help them continue to set future goals. So, I mean, much like we do a treatment plan with our clients, and once that goal is completed, we move on to another goal. Same thing with supervisees. Once a goal is completed, we move on to another goal. This goal may be trying to master a specific clinical skill. This goal may be kind of a promotion. This goal may be developing a new degree. Maybe you're supervising a peer support who wants to go back and get their bachelor's degree or master's degree. This can all be part of supervision. Again, you feel yourself, but there's a little bit of your own self-awareness as a supervisor in this stage, where you are starting to feel more comfortable being in a consultant role and actually relying more on the consultant role, where you're very comfortable with the supervisee acting much more autonomously than they had been previously. And again, and by doing that, hopefully you're establishing some confidence in the supervisee and developing a competence of skill. One thing we know about staying in the teacher role too long is if we're constantly teaching and we're never allowing the supervisee to practice what's being taught, we don't develop competence. We want to make sure that they're practicing what we're teaching. They're telling us what they're doing versus us always telling them what to do, even if our intention is very good. Then finally, the integration stage is kind of that final stage of supervision. It doesn't mean you're done with supervision. It just means they're at that stage, and the process of supervision looks different for supervisees in this particular stage. This is when they're, again, working much more independently. They're reporting back to you what's happening. They've got a nice competence of their counseling or nursing or whatever skill that they're working on. They come in with their own evaluations, their own reflection, and they're doing a lot of more self-supervision. They're telling you what's working and what's not working for them, and then having the evidence to back that up. Again, this is where we want supervisors to reach. And again, where we're almost doing very little teaching and much more consulting, much more listening, when in some ways they're teaching us. Again, going back to the student that I talked to that wanted to compete with me for a job, that's exactly what we want. We want to kind of learn from our supervisees, where now they're no longer a liability in our practice, but actually an asset to us. That they may be taking on greater leadership roles. I know for me personally, nothing really makes me more proud in my work when I see a former student, a former supervisee kind of move up within the first episode field. We've got a handful of individuals in Oregon that have either been my students or supervisees who are now clinical supervisors themselves, or trainers, themselves in our practice. And that's exactly what we want. We would like our supervisees to put us out of work. I've gone over just a few of kind of larger models where I talked about the discrimination model. I talked about the developmental model. There are a ton of models in supervision, just like there are a ton of models in clinical practice. I'm just going to go through a few models very briefly so you're aware. And I do have articles on all of these models, so if you're interested in one particular model, you can reach out to me directly. My email's at the end. I don't think I want to send out a ton of articles to everybody, but if you're really interested in a specific model, whether it be the discrimination model, the developmental model, or one of these models listed, I'm certainly happy to send you articles and other resources on particular models. So one model is the interpersonal process recall model. I love working in this model. I wish I could do it more. Don't have the opportunity as much as I used to, but it's a model which does involve videotaping of sessions, where the supervisee does bring in videotaped sessions of their clinical work, and it could be any clinical work, whether it's social work, whether it's supported employment, whether it's peer support. It really doesn't matter. You can look at it all, and then you watch the video with your supervisee. And then you are very deliberate as the supervisor. Sorry, it looks like I have another connectivity glitch, which I take care of very effectively. where you're working with your supervisee, where you'll notice something in the video. Maybe you'll notice a reactivity. Maybe you'll notice a specific skill, where you'll stop the video and then ask the supervisee, what just happened right there? I noticed that you made a shift from a CBT technique to more of an interpersonal technique in your work. Can you talk about what your decision was? What the research shows around using video in supervision is that the supervisee is much more effectively able to recall what was happening in that moment when they actually see it on video versus without video saying, hey, so you're doing CBT with that client. What was happening then? Memory, as we know, is quite flawed. But when we see a video of our own work, we're able to recall what we were thinking, feeling more accurately than just recalling it without that visual cue. It's a nice way to do supervision, to kind of integrate video back in. A relationship model is kind of what it sounds like. It focuses very much on the relationship between you and the supervisee. And the core component of this model is that one thing to remember as a supervisor is that our supervisees can sometimes feel alone in the world, meaning that they have huge expectations. They might have expectations around certain productivity, like they have to get so many hours or so many billable hours. They have to follow this specific fidelity model. They have to get these outcomes. And then when those things aren't reached, sometimes they can feel judged. Or if something terrible happens to a client, such as a client dies by suicide, if it was their client, they can feel like they potentially played a role in this and kind of feel blamed. Where in this model, we're really aligned with the supervisor, so they don't kind of feel alone, where the supervisor and the supervisee are aligned as partners. Again, this of course assumes that the supervisee isn't doing anything egregious or dangerous, but they're spending much more time on empathy and, how the supervisee may feel if they had a client that died by suicide versus, well, we probably better get that inspection done and see what you could have done differently. Not that we don't have to do those things, but really focusing on what interpersonally is going through a individual when they have a client who dies by suicide. Or, anything. Don't meet even something as potentially as benign as not meeting quite a fidelity score or a productivity level. Kind of understanding what barriers, what systemic barriers are getting in the way. I've been trained in the feedback-informed treatment model of supervision, and one of the case studies that I got to review in our training showed a supervisee who was very ineffective in their practice. And the trainer asked, well, what should we be doing with the supervisee? And of course, we bought right into the hook that this trainer wanted us to do and talk about how we're going to retrain them, how we might have to put them on a discipline plan, blah, 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 all this stuff. But what we failed to look at were the larger systemic issues in which this particular supervisee in this case study had a huge caseload. And we didn't pay attention to the research that showed once caseloads start exceeding 35, outcomes start dropping regardless of how good of a clinician you are. So really so that shifted our focus, like, we should have aligned more in a relationship model with that supervisee to help support them in some of these systemic challenges that are potentially resulting in their poor outcomes, not that they're a bad clinician. Parallel process model is a model where you pull up potential parallels to the supervisory relationship that exists in a counseling or in a clinical relationship. For example, the supervisee that is reluctant to engage in homework that you may assign as a supervisor, you can parallel that to when they're working with clients who are reluctant to doing their CBTP homework. What might be going on with those clients may be a similar process to what's going on with a supervisee. There's a wide range of theory-based supervision models, and in these particular models, you take the very specific theory that you're trying, theory or intervention that you're trying to teach, and that becomes part of your supervision model. For example, there's a cognitive behavioral therapy supervision model, and in that particular model, you're teaching CBT skills as part of supervision. So we know, if you're familiar with CBT, you know that there's an agenda that is set. In CBT supervision, you set that agenda in the same way you'd set it with clients. I've been trained in the feedback-informed treatment supervision model, and in that particular model, it's all about, does the supervision lead to good clinical outcomes? Just like in the clinical model, it's not necessarily about practice, it's about outcome. It's the theory that's applied directly to your supervisee. Then there's models that aren't quite as helpful. These are your unstructured models. There's the no model of supervision, and these, again, are not necessarily real models, but what sometimes happens in supervision practice. So the no model is the supervisor, and we're all guilty of this, that says, my door is always open. We don't need to schedule regular meetings. Just come in whenever you need something, and we'll just deal with it on the spot. Oh, you know what? I'll run into you in the hall. We'll count this as supervision. We talked that 5 minutes over lunch about that client. That's supervision. That's the no model. It doesn't have structure. My door is always open. I'm always available. And again, that's not me saying, hey, you shouldn't be flexible and available. You should always be available to your supervisees if they need you. But it's not having that structure around supervision. It's not having that designated time. It's not having that deliberate practice around supervision about what model you may be following in supervision. There's the expert model, where you as the supervisor act as an expert, and you're constantly in the teacher role. You need to do this. I don't know if you tried this. You should do this. You should do this. Where, and again, that's kind of our own, probably kind of our own feelings of inadequacy, where we don't really want to learn anything ourselves, where we just want to teach, the supervisee, what to do. There's the one-size-fits-all model, which we treat all supervisees the same, regardless of development. We have a set agenda. We do these things. We do case conceptualization in this way all the time with everybody, and not pay attention to where they are developmentally or what role we may be playing. And then there's the supervisee as patient model, which is assumed in some ways that supervisees are ones that need to be watched and monitored because they're inherently unhealthy and not able to grow. So we need to monitor them versus teach them or kind of help them through the supervisory process, because they're just here for a job and they're just here for a paycheck, and they don't really have goals around personal growth. But a lot of secrets, less transparency in these type of models. And then that particular model, the supervisor's patient model. Okay, let's kind of talk about some specific challenges in first episode psychosis program supervision. Challenges and as well as opportunities, actually may be a better way to put it, frankly, that we have in working in integrating supervision in first episode psychosis programs or coordinated specialty care models of supervision. One, when we're working in these models, we know, as you're probably all aware, if you're familiar or working in a first episode psychosis program or a coordinated specialty care program, there's very specific models with sometimes different expectations, sometimes competing expectations. You may be integrating, an ACT level, an acute assertive treatment fidelity, and you might be integrating an individualized IPS supported employment model. You might have all those different expectations. So what this forces us as supervisors is to not only attempt to monitor growth in our supervisees, but now we also have to monitor how close they're paying attention to fidelity, which, again, I don't think is a terrible thing. I just think we have to lay out what role we're going to play. Are we going to be supervisor, or are we going to be fidelity monitoring? I think the good news in a lot of fidelity practices is there's an outside fidelity monitor who can play that role. We certainly, and I would still want to more align with my supervisees and what skills they need to kind of help, meet fidelity. And frankly, if there's something that doesn't work where fidelity is not going to be met because of the challenges of our program, I'm going to support our supervisees and working with the fidelity monitors to kind of make that adjustment. But there's a wide range of skill sets also in coordinating specialty care models. Oftentimes, at least I know in Oregon, and maybe true for you as well, but our clinicians, regardless of their discipline, are expected to do community education, meaning that they need to get out in the community to educate the community about the early warning signs of psychosis and how to refer to those programs. Some clinicians are very comfortable with public speaking, others are certainly not. So with those, again, that's kind of paying it, you're almost bringing in a skill that you may not even be familiar with as a supervisor around how to do community education. So we ourselves need to learn and grow on how to coach people on doing skills that may not be in our own clinical toolkit. But again, understanding how comfortable people are, can they have mentors that are a little bit more effective? Are there outside resources that can help them learn how to do community education? Can you use videos to show people just different approaches that we can take to help our supervisors maybe engage in something that maybe completely new to them, and frankly, it might be even new to us. There's certainly a steep learning curve. Almost everybody who enters a first episode psychosis program as a clinician is learning something new. I know, we're learning kind of different models. We're learning potentially how different diagnostic assessments. I mean, have all sorts of degrees behind my name, but I had never heard of the SIPS, the Structured Interview for Psychosis Risk Syndrome, until I entered a first episode psychosis program, or started working with prodromal individuals in our own first episode program. So I had to learn a completely new skill. I went from a very integrated clinician in terms of the practices in our first episode program to now almost back into an early developmental stage. I had no idea how to use this instrument, and neither did my supervisor. So I had to, again, for the work that we had to do, I had to get coaching from outside people to really focus on that clinical skill. And then what I got in supervision was, again, support and how to develop that clinical skill, and as well as my own kind of frustrations with kind of learning it and other challenges that went along with that. We've kind of addressed earlier caseload management. We oftentimes, as a supervisor, you're responsible for a team of clinicians, and oftentimes you might be responsible for a team of clinicians of different disciplines, and trying to manage how caseload gets distributed. Too oftentimes, I feel that so much of the caseload gets distributed to the social workers, the psychologists, the counselors on our team, and then our occupational therapists, our nurses, our peer supports don't have caseload in the same way. So you kind of have to manage that so the workload kind of feels certainly equitable, or maybe there's an opportunity for the nurse, your occupational therapy, your peer support to take on a caseload, particularly if that client has a very specific need that matches their discipline. But kind of being transparent about that. Maybe you might actually engage in group supervision, which we didn't talk a lot about in this particular webinar. If that's happening, that should be brought up, and it's kind of talking. We have to be talking about those elephants in the room. We have to be talking about potential inequities that may be occurring, that might be perceived by clinicians when it comes to caseload management across disciplines. Homeostasis doesn't facilitate growth, so sometimes you have to talk about discomfort to move us forward. So that all kind of goes to multiple disciplines kind of working together about honoring all the disciplines that work together as equals. So you may be on a team with a psychiatrist, a nurse, a social worker, a counselor, a case manager, a peer support, an occupational therapist, a supported employment person. You have to be very kind of clear that although each of those disciplines actually has an evidence base that shows they're effective, not one is more effective than another. The effectiveness comes when the client perceives that particular discipline is helpful for them. So that's why a team approach can be so important. So we want to be very careful in this, and I've seen this kind of happen in our borough programs where there starts to be this turf wars and discipline splitting, It's just something we have to pay attention to in supervision. And then you, as a supervisor, can supervise that process. Where you may not be able to supervise is the skill development of a specific discipline that you don't have. For example, if you're a psychologist, you can't supervise kind of the very specific clinical development of maybe a nurse. So they may have to go outside for that. But you still can address, again, the coordinated specialty care model, any conflicts within the team, biases that may be coming up. That all can be part of your supervision. We also work with a pretty diverse population, not only diagnostically at times, but also age. Coordinated specialty care, FEP programs I've seen wider age ranges. Our program in Oregon is around 12 to 25 with some flexibility. I've seen other programs from 12 to 40. These are wide ranges of ages. And so now we're actually working with supervisees who, in terms from a developmental lens, or integration of a developmental model of supervision, experienced clinicians with adults now are working with children and adolescents, which they have very limited experience. I think it's important to acknowledge that, and then you then have to shift yourself back as a supervisee, probably back more into the teaching role, or helping them get those specific skills. At the same time, still acknowledging that they've had a ton of experience in the adult world, but working with children and adolescents is a completely different animal. Again, I have a ton of experience working with adults, adolescents, and that transition age youth. If I ever become work in a geriatric field, I'm starting from scratch, and that's just, again, kind of, so it's not so much about experience as it is skill sets or new interventions, as well as very specific populations. And again, the integrated supervisee is going to welcome that and going to be seeking feedback from you and seeking opportunities to learn when they're working with clients that they have limited experience with, or an intervention that they have limited experience with. So part of our role then is to help facilitate that. And a good reason to really help supervisees become fully integrated and become fully develop really formal skills in coordinated specialty care programs and specific interventions and coordinated specialty care programs is because we experience a high amount of turnover in these fields. As we experience, a lot of our first episode programs are not immune to the level of turnover that we see in community mental health centers. It's very similar in a lot of ways. With that, when somebody leaves, education and experience is lost. We need to be very deliberate in making sure that education and experience is translated to our supervisees. So when somebody leaves, we have somebody else that can start training them. So I think this that kind of train the trainer model are really being deliberate to move our supervisees to make sure they're mastering the skill sets in first episode programs so they can help us train the new staff as turnover occurs, so we can become sustainable within our own system. It should be, or at least a goal for you to consider or be thinking about as a supervisee. If I lose two of my staff, who do I have that can help facilitate their growth? Which I think you as a clinical supervisor, something that I know I've personally tried to take on as a supervisor, is really to try to master as much of the interventions as I can, so I can continue to be a trainer, and a supervisor, in Oregon for new staff. Some of the challenges that certainly occur within first episode programs, but I don't actually think that they're much different than what might occur in community mental health overall. All right, coming up to the end here, I did say I would give you some resources. I did cite Bernard's Discrimination Model, Campbell's textbook on essential in clinical supervision, and Stollenberg's Developmental Model. Again, I have articles from Bernard's work and Stollenberg's work, and if you're interested in those, you can email me directly. I did put a link to the ACEs, that's the Association for Counselor Educators and Supervisors, best practices in supervision. It's a nice document which kind of lays out some of the research around clinical supervision, and much like we have best practices in mental health, we certainly have best practices in supervision. So it outlines those. It certainly comes from a counselor lens, but I think there is actually a lot of crossover for psychologists, social workers, psychiatrists, occupational therapists, and all of the roles that are in coordinated specialty cares. And these are kind of broad-based recommendations around supervision and not necessarily discipline-specific. So that's why I like this particular documentation, this document. And then kind of that being said, everybody needs supervision, regardless of your role. I think I think the field that sometimes misses supervision the most in the first episode psychosis programs are our psychiatrists and our prescribers. They're seen as the experts, and they certainly are experts, because we're all experts in our own disciplines. Sometimes they don't get, because they're so busy, because they're considered experts, they don't get supervision around biases, around even their own professional growth. So I think it's important for us to pay attention to that we can, regardless of our discipline, supervise other disciplines. We just have to watch, obviously our limits of practices, but supervision is more than just teaching a specific clinical skill. Hope that was taken away from this particular webinar. Like you always, to stay connected with us if you are interested. Please follow us on Facebook. We've got a nice set of resources in there. If you're looking for resources specific to our program that may be useful to yours, you can go to esacommunity.org. And as I mentioned, here is my email, my@OHSU, that's Oregon Health Sciences University, .edu. And you can email me if you have follow-up questions from this webinar, or if you have an interest in one of the articles or some of the resources that I cited today. We have about 10 minutes left in our time, so I can take questions if you have them. Oh, thought I saw somebody typing, and then they went away. If you do need to go, or feel yourself needing to go, I do want to remind you that I announced, back to what I announced earlier today, that the technical assistance team will link a survey on kind of the usability of the system, and how we can better serve you on these webinars. So please take the opportunity, if you have the time, to complete the survey. Oh, it looks like it's up now. So if you have a moment now and you have no questions, I would encourage you to give us feedback so we can continue with our own growth mindset and continue to develop to make these more useful to you. You can also take the opportunity to register for the next webinar on February 22nd on integrating early psychosis into systems of care. Tamara is asking, how frequently should supervision be scheduled? If we go to the best practices manual, we say that clinical supervision should be scheduled weekly. So that's kind of your best practice, to have weekly supervision at the clinical hour of 50 minutes, so an hour-long supervision every week. And that's best practices. I also fully recognize that may not be available in programs, so every other week is an option. So ideally weekly. Try not to go less frequently than twice a month. Again, if you're going twice a month, integrating homework and other developmental skills in the meantime it makes sense. So if you're not one that can supervise someone directly, say you're supervising a nurse, maybe in those off weeks that you're promoting or helping them get some outside resources to help develop their clinical skills. Pause at this moment as I'm waiting for, it looks like a couple people are typing. Jennifer Parker Frey is asking about receiving an email acknowledgement of participation. Is that something that can be done? I think that's probably a good idea. I imagine licensing boards and others might be interested in knowing that people participated in a supervision webinar. Samantha is asking about how often for group supervision do you suggest? Again, I think a lot of the best practices will say that group supervision is incredibly valuable, and group supervision becomes valuable, again, much like individual supervision if you're following models, if you're following a structure, that people know what to expect when group supervision, whether it's going to be a case consultation model, whether it's going to be more of a process group on a specific reaction that may be occurring. So again, it's like individual supervision, it's good to have a model in group supervision as well. Most will say that group supervision shouldn't exceed what you're getting in individual supervision. So if you're doing supervision, once, or twice a month, group supervision could be done once a month. Or maybe you could do group supervision once a month and individual supervision once a month. One thing about group supervision, again, I didn't touch on it as much in this particular webinar, group supervision isn't your team meetings. Team meetings have a much different practice in terms of working very specifically on how a team is going to work with particular clients. Although sometimes there's some learning that happens in team meetings, those aren't supervision. Again, the pause here, just to be transparent, looks like some people are typing, so I'll give that a second. So Tamara's asking, for supervisors with limited knowledge of coordinated specialty care, how do they work with consultation to gain skills they need? So this is kind of going to consultation versus supervision. So I think it's an incredibly, really good point that supervisors, because we want to have sustainability within our programs, we do want the supervisors to kind of be the champions of the coordinated specialty care models kind of within their agency. So, of course, would encourage supervisors to get their own supervision or consultation around coordinated specialty care models. So maybe they're working with us at ESA or working with RAISE or PEER or some of the experts in the coordinated specialty care models to get ongoing consultation about those models. Our website offers a ton of resources and links on coordinated specialty care, videos, all that to kind of help them start to get up to speed in coordinated specialty care. But much like supervisees, this isn't a one-shot process. I would encourage supervisors to continue to get ongoing consultation, and really would be consultation unless they have someone in their agency who's an expert on coordinated specialty care, to get consultation from the national experts, again, whether that be us at ESA, RAISE, Navigate, some of those other models out there. And we certainly have links to those on our website. Great question, Tammy. Okay, it looks like the typing has ceased. Again, I will send the documents that I promised, the supervision agreement, supervision plan, and the supervision note, to our hosts so they can be sent out to all the participants. And I really appreciate you all spending your time this morning and afternoon, depending on which coast or time zone you're in, with us this morning. And I look forward to seeing you all again on future webinars. And again, feel free to reach out to me at my email should you have any questions or follow-up. Thank you very much. Have a great afternoon.